we should think in a systematic way. So first, we should ask ourselves, where is the pathology? In order to help you answer this question, I'm going to remind you with the ABC Dr. Dalia discussed first. Is the pathology related to the air spaces, bone, brain parenchyma, or can we see blood, or related to the CSF spaces? So back to the CT cuts, I think the answer to this question is simple. The lesion is related to the brain parenchyma. So next, we're going to ask ourselves, what's the radiological finding then? In image A, we can see that there is bilateral cerebellar white matter exaggerated hyperdensity, as well as bilateral temporal region hyperdensity. In image B, we can see that both thalami are swollen, showing central hyperdensity. And in image C, we can see that there is bilateral periventricular white matter hyperdensity. Next, let's go to the MRI findings. So, again, systematically, we're going to ask ourselves, where is the pathology? And the answer is, it's related to the brain parenchyma, like the CT, mainly involving the thalami, as you can see. So, what's the radiological finding then? In the axial T1 sequence, both thalami are showing low signal intensity. And in the axial T2 sequence, both thalami are showing high signal intensity lesion, as well as both optic radiation regions on both sides are showing high signal intensity. In the axial T2 star sequence on the right, we can see that both thalami are showing central areas of low signal intensity, which denotes bilateral thalamic hemorrhage. Here on the left, we can see the axial diffusion sequence, which both thalami are showing high signal intensity, and on the right, the axial ADC sequence, in which both thalami are showing low signal intensity, which denotes bilateral symmetrical thalamic true diffusion restriction. Similar findings were noted in other sites. Those sites are, here both cerebellar hemispheres are affected, as well as both temporal regions, the tectum of the midbrain, and the corona radiata. So, to sum up, the MRI findings noted were bilateral symmetrical areas of signal alteration, noted mainly at both thalami in the form of low signal in the T1 sequence, high signal in the T2 sequence, true diffusion restriction, and bilateral thalamic central areas of low signal in the T2 star sequence. So, what's the diagnosis then? This is a case of acute necrotizing encephalopathy. This is a condition that affects multiple brain areas, but mainly both thalami are affected, as we have seen in the CT and MRI images. On follow-up of the patient, the MRI images revealed residual gliosis in the optic radiation, as we can see in the axial MRI image on the left, and residual gliosis in both thalami in the axial MRI image on the right. And this correlates with the clinical presentation of the patient who presented after the management with only visual affection. And this is related to the gliosis noted in the optic radiation region. So now comes the question, what is the differential diagnosis then? The most important differential diagnosis to the acute necrotizing encephalopathy is deep cerebral venous thrombosis with bilateral thalamic infarction. So how can we differentiate? First, by the CT. If the internal cerebral veins show hyperdensity, as we can see here, then this is deep cerebral venous thrombosis. Unlike in the case of the acute necrotizing encephalopathy, the internal cerebral veins are normal, showing no signs of hyperdensity. Next, how can we differentiate? By the conventional MRI images. On the left, this is a normal MRI brain T2 sequence in which the internal cerebral veins are signal void. On the right, this is the deep cerebral venous thrombosis in which we can see loss of signal void in the internal cerebral veins. In our condition, the acute necrotizing encephalopathy, the internal cerebral veins are signal void exactly like the normal MRI brain. And for further final confirmation, we will proceed to the MRV. In case of the acute necrotizing phallopathy, the internal cerebral veins will be normal, showing normal flow, as opposed to the condition of the thrombosed internal cerebral veins on the right. There will be no visualization of the internal cerebral veins, denoting lack of flow. So, as a take-home message, I want you to remember the following points. Acute necrotizing phallopathy of childhood is characterized by multiple bilateral brain lesions, mainly involving the thalami, yet other sites could be affected, like the internal capsule, the cerebellar white matter, and the brain stem. In the CT, we should look for the internal cerebral veins to rule out deep cerebral venous thrombosis in case they are markedly hyperdense. If we're still in doubt, we should proceed for the MRI, remember the conventional T2 sequence, and finally the MRV. Thank you so much.
يعني الحقيقة بس أنا عايزة أشكر المخرج اللي عمل إخراج للمسرح النهاردة. الدكتورة شيماء عبد الستار طبعا ومعها الدكتورة عبير والدكتور خالد. إحنا بنعمل بروفا على فكرة من يناير. احنا كنا كل